Welcome to our live webcast, Popular Ultrasound-Guided Nerve Blocks for Pain, Part 2. Thank you for joining us. My name is Heidi Border, and I'm Senior Meeting Planner for ASRA Pain Medicine, and will be the host for tonight's webinar. We are happy that we are joined tonight by our moderator, Dr. Dennis Patterson of the Nevada Advanced Pain Specialists in Reno, Nevada, who's going to introduce tonight's topic and speakers. Welcome, Dr. Patterson.
Hey, thank you for joining us tonight. And I look forward to a continuation of the series of presentations that we've been doing here with ASRA and PAJUNK. I think initially the first presentation we did was just a general overview of ultrasound-guided procedures or common procedures to be done in the office. Myself and Dr. Rosenbloom did that procedure, and so I want to welcome him back tonight. It's great to have him, as it's always good to work with friends and see their faces. And so the second part of the series, we decided to kind of break it down and do more like large joint injections. And so that myself and my other colleague, Dr. David Russo, did that one a few months back. And now we're back tonight where we're trying to do more popular or common peripheral nerve blocks that can be done in the office under ultrasound. What I'd recommend is if you're looking for more of the backgrounds of ultrasound or technique or how to get better at doing ultrasound guided procedures, I would tell you to go to the PAJUNK YouTube page, and the two prior presentations are there. We didn't want it to get too redundant, and so we don't go into the specifics of ultrasound tonight because we didn't want to bore those who had seen the prior presentations, but I would encourage any of you who want to learn more about how to do ultrasound to please reference those. But tonight, I'm going to start sharing my screen here. We're going to go into this wonderful presentation. Hold tight. Let me go share. I got to go back to the beginning here. Presentation. And essentially, tonight, Dr. Rosenbloom and myself are going to be talking about, common peripheral nerve targets and best practices to kind of help a lot of your patients in your clinic. So just a little bit of background information about us if you haven't seen our prior presentation. So I am Dr. Dennis Patterson. I'm a physical medicine rehabilitation doctor who did a pain fellowship. I'm board certified in both. I'm the founder and owner of Nevada Advanced Pain Specialists in Reno, Nevada. I've been very fortunate to have a pretty successful career. I ran a co-management with Northern Nevada Medical Center. While doing that, I've been nominated twice as one of the top 25 doctors in Northern Nevada. Just last year, I won Innovator of the Year in the middle of the pandemic about offering newer procedures to patients while doing it. So it's been quite a good 15-year career. Dr. David Rosenbloom, who is done just as many amazing things as I have. He is the director of pain in the Maimonides Medical Center. So he kind of has a co-management with them, but he does run his own private clinic, which is the AABP Integrative Care. He's in Brooklyn, New York. But not only that, on the side, he runs pain exam to kind of help people pass the pain boards, which he will kind of highlight a little bit later. Here's our disclosures prior to giving tonight's presentation. And our contact information. I know David's very good about this. I'm very good about this. Feel free to reach out to us with any questions after tonight's presentation. We'll try to monitor the chat, the Q&A as we go. We'll try to answer questions live, and then we'll have a Q&A at the very end. So hopefully it'll be an interactive dialogue. We can answer some questions. People go away learning what they've come here tonight to want to learn. But if for some reason we miss that, feel free to reach out to either one of us. We will get back to you as fast as we can. Usually it's a turnaround within 24 hours. So once again, our topic is the overview of training peripheral nerve blocks for pain. We kind of threw multiple nerves out there and kind of found that the most common ones that people want to learn about were the lateral femoral cutaneous nerve block, the greater occipital nerve block, and an intercostal nerve block. But I think, as we all know, there's, the principles that we're going to be talking about tonight apply to several nerves in the head, neck, upper extremity, trunk, and lower extremity. So you can see there's plenty of nerves that we can block that can cause pain in patients. And so we're not saying these are the only 3 blocks you can do in your office. Actually, any of the nerves listed here could be a potential target, and the same principles that we're going to talk about tonight can apply to that. So we're going to break it down into the 3 different nerves. I'm going to do the lateral femoral cutaneous nerve block section. Then I'm going to turn it over to Dr. Rosenbloom to do the greater occipital nerve block section. Then it'll come back to me. I'm going to talk about intercostal nerve blocks. Then we're going to wrap it up with highlighting PAJUNK's sonoplex needle. That's going to be the main needle that we're doing tonight, since we're talking about peripheral nerve blocks, not their Sono MSK needle. Sono MSK is more for your great joint injections. That's what Dr. Russo and I talked about last month. So let's dive into the lateral femoral cutaneous nerve blocks. Essentially, this is a mononeuropathy pain condition of the lateral femoral cutaneous nerve, or otherwise known as meralgia paraesthetica. So these are patients who are going to present to your clinic. They're going to talk about how they have pain over the thigh area. And, I'd be curious to see if Dr. Rosenbloom would agree, but I've seen a lot of patients, we're spine specialists, right? And so I've seen patients who've gone to other clinics, and they come to my clinic telling me, oh, I've already had an epidural. I've been told I have an L3 or L4, disc herniation in the back that's causing, L3, L4 ridic down my leg. They did epidurals and it didn't work. And so now I'm coming here. And when you really dive into the history, you find out that it's not in a dermatomal shape. It's more in an oval shape over the lateral thigh, which is exactly what you're looking for. Is that, as I show here on the screen, that lateral shape is what the patient should have. So it's commonly missed by some providers. They blame it as an L3 or L4 ridic. So always remember to ask if it seems like it's in a circle or oval shape for the patient. Typically, this will cause anesthesia, lack of sensation in the nerve area, but when it becomes painful and becomes meralgia paraesthetica, it'll be more of a burning type sensation that can cause significant pain and disability for patients. Other descriptions you may hear is they may describe it as a coldness, a lightning pain, may be shooting, deep muscle tenderness, and they may even describe have the lack of hair loss over that area. The typical patient I see with this is usually somebody who has had rapid weight gain. So I think a lot of us during COVID, when we were locked up, probably essential business with alcohol, drinking, and gaining weight, we probably had some. I've seen a few patients that have developed meralgia paraesthetica because they were just not active or not doing as much. Pregnant women, the gain of weight during pregnancy. Other people can be specialties where they wear tight belts. So it could be a construction worker who wears a tight belt. It can be a police officer, or it could just be somebody trying to make a fashion statement and wearing their skinny tight jeans. That can be known to pinch the nerve as well. And so that's kind of the typical history you're going to see. Now, the sensory output is typically the L2, L3. It derives from those nerve roots, but it can be variable. So if it's not L2, L3, it could be L1, L2. It could be L2 alone, or it could be L3 alone. This nerve does pass through the inguinal canal or inguinal ligament with the femoral nerve. So that's why it's kind of crucial to do this under ultrasound guidance, because after they separate, you want to make sure you don't do the injection blind and poke the femoral artery. That would not be a good situation. And typically this is found about, I usually describe it as palpating the ASIS, about 2 fingers breadth down and 2 finger breadths lateral. And so if you get more specific here, you can see here, usually when I'm using ultrasound to locate this nerve, I'm going to scan medially. I'm going to use usually the not the linear probe. I'm not going to use the curvilinear probe because it's more of a superficial structure. I'm going to locate the great vessel medially, and then I'm going to scan over the top of the iliacus. So as you see here on this image on the left, that's the edge of the iliacus. As the not the iliacus, it's the sartorius. And when the sartorius tapers down laterally, right in that compartment, you will see the lateral femoral cutaneous nerves. If you're too far inferior, it's not going to be one big nerve. You may see 3 different fascicles or 3 different nerves after it splits and goes to innervate different parts. But if you scan up a centimeter or 2, you'll see that those 3 fascicles come together to form one nerve. Just inferior to the sartorius is the iliacus. And so usually before I even grab the ultrasound, I'll use 2 finger breaths below the ass, 2 finger breaths laterally, kind of mark that area with a skin marker, clean and prepped area, start scanning medially, and then, see the great vessels, go over the top of the sartorius and locate that compartment where it tapers down. Ultrasound is going to be held more not vertical, but horizontal across the thigh. I'm going to invite Dr. Rosenbloom to come on. This is one of his patients. I'm going to have you tell him about it. And then I'm going to play a video showing him performing a lateral femoral cutaneous nerve block.
Thanks, Dennis. So, here's a video of a patient who's basically an overweight 40-year-old patient who has severe meralgia paraesthetica. I don't see so much of this problem. You can see the nerve right there with my needle approaching it in the fat pad lateral to the sartorius muscle. And that's the nerve before it bifurcates. There's also a little blood vessel there. I don't know if you see that pulsating. What I can say about this disease or this condition is I don't see it very often, but when I see it, it is impressive. I mean, it is severe to the point where these women are, or these patients, I should say, are almost crying, begging for injections on the date of the evaluation, as well as any follow-up visit if they're coming in post-injection. And the nice thing is you can find the nerve. It's amenable to the block. The trick is really figuring out how to make it last longer. And there's all sorts of ways to do that: peripheral, spinal stimulation, DRG, et cetera, and ablation, of course. I do have one patient who came to me after seeing other pain doctors, and they actually, she's been through surgical decompression. She's been through everything. One thing she told me, which kind of I found really funny was one of the pain doctors she went to used the old-fashioned technique of just stimulating the nerve without an ultrasound. And maybe 20 years ago, 15 years ago, that may have been more acceptable. But I think in this day and age, almost everybody's using an ultrasound to find this nerve.
Yeah, I agree. Now, on your video here, David, was that a standard spinal needle, or were you using a PAJUNK Sonoplex needle on that video?
I believe this was it's funny. She was a large woman, but you can see here, it's 1 centimeter deep, right? The notch is on the side of the screen. So it wasn't very deep. It's a very superficial nerve. That may even be a 1.5 inch needle. If not, it's either a spinal needle or a 1.5 inch 25 gauge needle.
Yeah, I agree. I think this needle is a lot more superficial than you think. And I think especially when you're using ultrasound, you have to almost change your depth gauge to show the superficial structures better. So if your ultrasound beam is going too deep, you're not going to see it more superficially. So you really have to zoom up. And you're exactly right. I mean, it's superficial. So I think a lot of times you get to see that. But yeah, I mean, you got pretty good, since it's so superficial, you got pretty good imaging of your needle. But as you can see, it's not perfect. It's still hard to see, but doing the bouncing technique and kind of moving around and injecting a little bit, you can see where your needle tip is. So the next case that we're gonna go through is basically my patient. I ended up doing kind of a head-to-head similar patient. I have this mid 40-year-old gentleman. He's actually kind of where I was joking earlier about a patient who gained about 20 pounds over COVID. I think it was the increased use of alcohol while being bored, while social distancing at home, because he didn't have any career or he's wearing tight pants or anything, and developed this lateral thigh pain. Initially saw his primary care. They got him an MRI, He was told he had neuroforaminal stenosis, saw a spine specialist. I think they ended up doing an interlaminar injection followed by a transforaminal, and they just never really diagnosed or gave him much relief. And that was kind of the first clue to me, like, hey, did anybody talk to you about this condition called lateral femoral cutaneous? And is this in the shape of an oval? And it was yes. And so that was my plan here, was to do a diagnostic block of the nerve, which included steroids. So not only would the local provided diagnosis if the pain went away, but the steroid could potentially provide a long-lasting resolution of the symptoms. And as you and I know, unfortunately, steroids aren't the holy grail. We hope they are, but if it isn't, we got other treatment modalities to kind of help these patients with which we can go and talk to about specific cases. And this one, it actually resolved his pain. It's been about 5 or 6 months now. He has not returned. Hopefully that's a good sign that the problem went away, and that I did him some good. But on our video on the left here, as you can see, you've actually got the compartment here. So this is the sartorius tapering down. The nerve is right here in the compartment, and I've got a 22 gauge spinal Quincke needle. So it's much more than what I need since it's so superficial. But as you can see, I'm even using wagging and trying to slide. I can see the needle, and I can see I get by the target, the nerves, the fascicles here, but I never really have good visualization of my needle, until the very end. So what I ended up doing on that same patient, after I finished the injection, I came back and I used the PAJUNK needle, and you can see immediately that I get just right where it tapers off, right by the nerve fascicles, the 3 right there, and took the needle out. So I just want to show that one more time on how clear that needle is. And Dr. Rosenbloom later is going to talk about why that needle shows up so much more clear than just a traditional spinal needle.
It's a beautiful image. By the way, one of those branches can go to the anterior thigh, not, typically.
Yeah.
I guess it's my turn for the greater occipital nerve.
Yes.
Okay. So yeah, the greater occipital nerve from C2, C3 nerve roots, and it exits and wraps around to go above the obliquus capitis inferior muscle up to the semispinalis. And then after it passes through that, it joins the occipital artery up by the scalp. Typically the occipital headache, we all see this, right? It's a very common headache in the pain practice. Goes along with the cervicogenic headache, right? It's a patient who has pain in the back of the neck, radiating up along the occiput. Typically there's a Tinel sign. And many of these patients have been through many other treatments that have not worked, the migraine meds, the NSAIDs, Tylenol, etc. And another funny thing about the occipital neuralgia I find in my practice is it sometimes coexists with typical migraines or other types of headaches. It's not always in isolation, and it definitely goes along with cervicogenic neck pain as well. So there are a few ways to do this. I used to do this blind, where we just palpate for the artery. And Dennis has a nice video about that later, higher up. But what I'm going to talk about is the approach coming low down at the level of C2. So C2 is the first real spinous process you're going to find, and it's bifid, which is not always obvious with the ultrasound, but here you could sort of make it out. And you're looking to scan lateral towards the lamina of C2 and look for the muscle layers. If you want to just press play on the video. Okay, so here we go. We find the C2 level, and I'm scanning laterally, and you see the hyperlucency right there. Okay, that's the region of the nerve. That's medial. The other side is lateral, and you have a little bone shadow at the bottom. That's the C2 lamina. And the first muscle is the obliquus capitis muscle underneath the nerve. And then you have a few muscle layers above it, the supraspinalis, the sponneus capitis, and then the trapezius muscle. And if you look at the right picture on the right, it kind of varies the way the muscles go as you scan up or down, but typically it's the semispinalis above the nerve. And the hyperlucency on the screen to the left of the arrow is where you're going to do the nerve block. I find that when I do this block under ultrasound, I'm using a lot less volume than the old school field block we would do at the occipital artery. And I can get away with 1 or 2 mLs And I usually come in just from the side. So I'll let Dennis talk about his technique right now. And there you go. You're on mute, Dennis.
Sorry, thank you. My technique is always finding the occipital protuberance and then going along the nuchal ridge and trying to look for the occipital artery, because as we all know, usually the peripheral nerves will be in parallel with the artery and the vein. So, VAN is always kind of what we've been taught. I did have a video, but I didn't include it in today's presentation, where I actually just scanned, just lateral to the occipital protuberance along the nuchal ridge, and you can see the artery pulsating. And I didn't even think on my presentation or my videos here, you're going to be able to see that. So on the left-hand side, I've just got an image of the ultrasound probe, kind of along the nuchal ridge where I've cleaned and prepped the patient. I'm going to come in plane. And what I'm going to try to do is, I believe that the blood vessel is right here for the left side. I'm going to play the video and you'll see my Quincke needle come in. And then I'm going to repeat the same procedure on the patient doing the greater occipital nerve. Now, when we're, you can do, for occipital nerve blocks, you can do the greater, the lesser, and the least. And typically the general rule is the occipital protuberance to the maneuver, or the, to the, oh God, the mastoid, it's a third, a third, a third. So it's going to go greater, lesser, and least. In this case, I'm just, a third of the distance over to the mastoid doing the greater occipital nerve block. So let's look at the one on the left. This is the skull. I believe the vessel, when I could see it with not much palpation, you can see it there. You can see my Quincke needle come in, and then you can kind of see an explosion as I got the needle tip next to the artery. And actually, you can see the needle a little bit better right there, once again at the end. So let's see that there's the skull. You can kind of see the needle tip or the tissues moving. The arteries right here. I want to get my needle tip right next to it. So there you go. Kind of see an explosion. I was a little superficial there, angled down because I couldn't see the needle. And then, I'm trying not to touch the cranium because it can be painful for the patient. So I'm trying to stay just superficial to the periosteum. Now on the right-hand side here, same technique. Now I've just, went back over to my occipital protuberance. I went a third of the way over. And now I'm trying to do it so that, since I was doing the left, I wanted to go right to left. And now this one, I'm going to go do left to right. So you're going to see my needle come in on the left-hand side instead this time. You can see the periosteum. You can see the needle. Unfortunately, I entered the skin a little too far lateral. But you can see I'm right, my needle's right there. I try to here at the end to kind of make up for it so you can see more of the needle to scan closer to where I entered the skin. You can see it, but the needle is really highlighted. It kind of looks like a lightsaber. I'm coming in, I'm just superficial. Artery is right above my needle, and then I injected. You can see the injectate going along the periosteum right there to get the target. So not more error on my part on not scanning more medially to get that needle in. But I think when you watch that video, you can clearly see, let's just do it one more time. You can clearly see that needle, where the other side we're watching more tissue move. But you can clearly see the needle come in, stay superficial to the periosteum, just inferior to that vessel. And then when I inject, you can clearly see the injectate going along the perineum, just right underneath that blood vessel. There's that.
Great shot.
Yeah. I try to, before I inject it, I try to hold still there because to kind of highlight the needle a little bit more.
Sure.
All right. Now we're going to move on and cover intercostal nerve blocks. And so this is a common thing we can see in the office. It's a little scarier. A lot of us don't have fluoroscopic machines in our office. So the prospect of doing this injection blind is scary. It can be pretty dangerous. You can give the patient a pneumothorax. Doing under fluoroscopy is nice. But the problem is, like I said, access to the fluoroscopy or having a fluoroscopy in the office may not be an option, where ultrasound doesn't have radiation and is cheaper to put in the office to carry out these procedures. This is actually one of the oldest peripheral nerve blocks known. It's been described as early as 1907. Once again, your injectate is usually a local anesthetic, for the diagnostic reasons or to make sure you block the right levels. And mixed with or without a steroid. Usually you're going to put a steroid there to give you the longer lasting benefit. Once again, the vein, artery, and nerve are just underneath the rib on the inferior surface. So you want to palpate the rib, feel the intercostal muscle in between, touch the inferior edge of the rib, and just kind of walk off 1 or 2 millimeters underneath the bottom edge of the rib to get the intercostal nerve block. If blocks help but don't last, you can do a neurolysis, whether it's with alcohol, phenol, or I've even done some patients with radio frequency ablations to help out. I think now, instead of being destructive, we even have different other non-destructive modalities, like either it'd be off-label, but dorsal root ganglion stimulators, or on-label a peripheral nerve stimulator along that. So there are 12 of these thoracic nerves. They're under the edges of T1 to T12. They're divided into the ventral and dorsal rami after they pass through the intervertebral foramen. They're, like I said, they're just underneath the inferior edge of the rib. They go along with the vein in the artery. When highlighting these under ultrasound, you've got 2 different techniques. You can go along the rib, so you're kind of in plane, or you can go out of plane, or where you're showing half of the rib on one side of your ultrasound image, while there's the intercostal muscle on the inferior side and highlighting the inferior part of the rib. These nerves provide sensation to the skin, muscles, and bones of the patient's back. Typically, I see it's patients who've had post-herpetic neuralgia, where they've had some type of cardiothoracic surgery where they had to split the ribs to go in to get it, that these nerves become affected and become painful. There's 2 CPT codes. There is the 64420, that's if you're going to target one level. The 64421 is if you're going to do multiple levels. You can add units to that. So if you did 3 levels, you do 64420 times 1, and then you would add 64421 times 2 units. You can also, for this procedure, add on ultrasound guidance, since that's not inclusive to the procedure. So, as I was highlighting earlier, you can do this procedure blind. It's not recommended. It isn't safe. The last thing you want to do is give a patient a pneumothorax. So you're going to have the patient raise their arm and put their hand behind their head. You're going to palpate the ribs to get your landmarks or the levels that you're trying to do. You want to do this down the mid-axillary line. And then with palpation, you want to feel the inferior part of the rib. You want to bring your needle down, touch, stay over the rib, touch it, and then walk your needle tip off inferiorly, advancing it only about 1 to 2 millimeters, and do the injection. Perfect. Ultrasound guidance. So we've got, this is kind of a cross section where you're going to have the rib. So we're looking at skin, adipose tissue, the intercostal muscle, the pleural underneath, and the lung. You're going to see the rib tissue. And as I said, the vein, artery, and nerve hide just under the inferior portion of the rib. There are plenty of articles describing how this is done. They can give you some guidance. I'd encourage you to get this slide deck from us and look these up. They can kind of help with it. Here is an example where we've got the ultrasound probe coming perpendicular to the rib. As you can see the rib right here. You can see the inferior edge of the rib where the intercostal nerve is hiding. You can see the pleura deeper underneath. So as you bring your needle down, you know the depth that you're at and can make sure that you don't go too deep and cause a pneumothorax. So the biggest complications that you're afraid of is the pneumothorax. As always, when you poke a needle through the skin, there can be bleeding or bruising, injection site pain. That's all normal. Infection, it's pretty rare. I don't know about you, Dr. Rosenbloom, but 15 years of doing peripheral nerve blocks in the office, knock on wood, I've never seen an in-office superficial peripheral nerve injection that's caused an infection. You do have to be careful, and that's why it's important to visualize your needle at all times so the needle doesn't puncture the nerve or cause a nerve injury. And then last but not least, it may not even have anything to do with your technique with the procedure. The patient may just have an allergic reaction or anaphylactic reaction to the medication being used to do the procedure. I'm gonna let you talk about your patient here. I'm gonna play the video.
Okay, thank you. So this is a nerve block from my YouTube channel about a patient who has post-mastectomy pain syndrome. As you can see, I'm doing the nerve block in plane, cross-section view of the rib. The pleura, notice it's moving, right? That pleural line, when that's moving, it's a great thing. They're breathing. When that disappears, pneumothorax, just as a side note. The transverse view in plane as well also shows, now I'm in a little different location here to demonstrate how superficial the lung is. It's less than a centimeter deep. If you look at the notches here. So the nerve is at that white arrow right there, and I'm infiltrating above here. So my point with this is you need to be very careful about these intercostal nerve blocks. I actually had one pneumothorax in my career. It was a patient that looked just like this, but she was 90 years old. And before I even found my needle on the ultrasound, I was already too deep. Luckily, it was a 25 gauge needle, so no harm, no foul, no chest tube. One of the doctors I work with had one of the residents give him a trigger point, and lo and behold, he developed a pneumothorax because the resident lost their needle. So you got to be very careful with this and know when you're in over your head. Yesterday, I was doing a paravertebral nerve block on a patient with post-herpetic neuralgia, and I realized she was a larger woman, and I wasn't seeing my needle well, so I switched to the PAJUNK needle. And it helped a great deal. I don't have the video for that, but it really made it easier to see what I was doing. Another interesting point about this particular patient who I'm doing these nerve blocks for post-mastectomy pain syndrome. She's a young woman. She opted for a cryoablation, which we did earlier this week. And she actually got numbness and pain relief proximal to the needle stick, but pain, post-procedure pain distal. And the reason for that is a couple of reasons. One, the proximal numbness is because these nerves, they come superficial and they will branch backwards to cover the skin. So you're actually doing a distal block, but getting proximal skin anesthesia because those cutaneous fibers are looping backwards as well as forwards. The other thing is she didn't completely respond to the ablation, so I'm probably going to have to repeat it because it was an incomplete ablation, in my opinion. Unfortunately, she was numb when I did it at the day of, so I couldn't tell. But that's just a side note about intercostal blocks. Now I think Dennis has some great videos for you.
Yeah, and I just want to comment on yours. I mean, in my 15-year career, I've had one patient I've given a pneumothorax. And it was early in my career. I didn't have access to ultrasound, actually. I bought my machine from my office. I did it under fluoroscopic guidance and ended up giving the patient a pneumothorax. You're exactly right. It wasn't detrimental to the patient. They didn't need a chest tube or anything. It was a very small one, but still, the last thing you want to know is that you could have caused the patient more harm. I think the patient ended up being able, it happened, how it went down is they were developed shortness of breath, went to the emergency room later. They got the x-rays and saw that they had the air and treated it conservatively, but the patient did spend the night in the hospital. And so that's just never fun to look that patient back in 2 weeks later. But knock on wood, using ultrasound guidance, I have not had that issue. Here's kind of, once again, I'm going to show you using a 22 gauge Quinky needle on the left-hand side. Just a kind of preference that you can kind of see the rib. The inferior part of the rib is down here. I believe the pleura is kind of more under here. My nerve, I'm not as good a video as Dave. I was explaining to David earlier that I think I was about an hour behind this day when this patient showed up, and I just didn't, unfortunately, in the last 2 weeks, haven't seen another patient who needed intercostal nerve blocks. But I tried my best to kind of highlight or give you guys an example of using a Quincke versus the sonoplex. So if we watch the video here, you'll kind of see on the right-hand side, you're going to see my needle come in. Got some decent visualization of the Quincke. I'm trying to come down here, touch the rib. The hard part is I'm kind of right down in this area, and I'm having a hard time. And actually, I was scanning kind of left and right. And in this case, this is the same level that I did on the right-hand side. But at the end, I wasn't doing multiple levels, and so I didn't want to inject with the Quincke. So I saved it for the sonoplex because I just didn't have confidence where my needle tip was there at the end. So you can see I kind of got down in the area and I pulled out. But let's go watch using the sonoplex needle. Once again, it was more my scanning, but you can see the needle coming in here. And eventually I'm going to do a little bit of a wag, and I'm going to really pick up the needle, and it's going to highlight it a lot better than I ever saw. Whoop, it kind of was real quick there, right there. Now you can see the edge of the rib. I can see the needle kind of down in the area. And at that point, I felt more safe doing the procedure. But like I said, I think that was more user error than it was a problem with the equipment that day, because unfortunately I was just an hour behind, and but no harm, no foul. It all went well. The patient, I just followed up with him a couple of weeks ago and has done pretty well. Dr. Rosenbloom was gracious to find a lot of articles on intercostal nerve blocks, and these should be a reference if you're ever going to do or want some more information on intercostal nerve blocks. Feel free to get a copy of our slide deck and look these articles up. I can tell you how they can help patients with different conditions, including post-herpetic neuralgia. And I think that brings us kind of what the whole point of tonight's presentation is not only to teach you about these things, but to teach you how to do these, best practices and safety. And part of that is your equipment. And Dr. Rosenbloom is going to talk a little bit about PAJUNK and their equipment and how may be able to make it so that you can do these injections, faster and safer for patients.
Thanks, Dennis. So what makes the sonoplex 2 and the sono-MSK so visible under the ultrasound is the 3 reflection panels. It basically maximizes the amount of waves that return to the ultrasound transducer, right? The crystals in the ultrasound are emitting waves, and the transducer picks them up and interprets them and forms a picture on the screen. I know we didn't really do much of the basic knobology and physiology, but most of us are aware of this at this point. And these needles can even be visualized at very steep puncture angles, which is an amazing thing because many times it disappears when you do that. And you can see here on these that Dennis just highlighted on the images how it's possible. So this was developed by Chris Mitchell, who's an anesthesiologist in Australia. And the structures allow for maximum reflection, and the tip and the whole shaft is visible. And there are actually several comparative studies proving that the sono needles have the best ultrasound reflection quality. The cornerstone reflectors are along the first 20 millimeter of the sonoplex needles, and I've really had some excellent experience using these in my practice. So the features of the needles, the reflectors are 360, which optimize the visibility of the needle shaft and the tip at any angle. The nanoline coating, exterior and interior wall, makes it easy to puncture, and it goes in smoothly. There's a fixed injection tubing. There's color-coded hubs, so you can easily identify the gauge sizes. And then there's the removable stimulation cable for sonoplex 2 only. The freedom to choose the stimulation option. I mean, I've used these for stimulation in my office, and I got to say, anecdotally, I had one patient who was post-op shoulder. She had multiple surgeries, had temporary relief from the nerve blocks I was doing for her shoulders and tendon injections, etc. I decided to do a stim trial on her. I did the stim trial with the PAJUNK needle, and it was the only thing that helped her. Not even the re-op, not even the nerve blocks. She never needed to get a peripheral nerve stimulator. Just the trial itself alleviated her pain. There's also different types of bevels on these needles, facet, sprott, TUI, and it's just a high quality product, and I've had excellent experience, and I encourage you guys to check it out. So it's quite what we just talked about. It's very reliable at any angle, and I think the more blocks you do, the more you'll appreciate that the angle does make a difference. And of course, with any of these needles, whether it's the reflective with the reflectors or not, you need to practice your needling. But once you get into the deeper tissue, it's going to make your life a lot easier, like it did for me yesterday when I switched to the Sono MSK. And if you guys are interested in board review for pain, anesthesia, PM&R, or ultrasound training, check us out. This is the QR code. You could just scan it and you can register for our online or in-person workshops. Thank you. Thanks, Dennis.
Yeah, no, thank you. And, if you're looking for some more information, as I was alluding to, we've got 2 other presentations, plus PAJUNK has other educational events on their YouTube channel. Please look it up. It's not only that, if you're interested in getting some educational posters on their stuff, all you have to do is send your name and your address to info@pajunk-usa-com, and they will send you these posters. It definitely talks about different upper and lower limb nerve blocks that can be done, especially for regional anesthesia. We do in the Q&A box, we have 3 questions. I figured since we weren't getting overwhelmed, we wouldn't type in questions while we were presenting, and that we'll go through those 3 questions, see if any others pop in, and at that time we can adjourn for the evening if there's no other questions. The first one is, are the links to the previous slides available? So I showed that slide where the presentations are, but is there a way to access, Paulina, the actual slide decks that they can download?
Not at this time, but if they email the info box, I can send that to them.
That would be awesome. And I'm sure Dr. Rosenbloom, I have no problem sending the slide deck or my slide. You think? Okay, good. I figured you wouldn't have a problem with that either. The next question we have is, how do you perform your occipital nerve block with clean aseptic technique? Do you want to take a first stab at that, and then I'll follow up behind you?
Sure. I usually will just use alcohol. If I'm really concerned, I'll use chlorprep or chlorhexidine.
Yeah, I'm just using iodine, providine swabs. But I mean, bottom line, the head and neck area is so vascular that the chance of infection is slim to none.
Never seen it.
Yeah, I've never seen it either. And I even joke, I've got a funny story to tell. I actually, I'll keep names out of it, but went and did a peer-to-peer, wanting to learn another technique. I won't even say what it is, and ended up going to San Diego to this guy's private clinic. And the patient shows up. She's about in her 60s. He said, "Oh, I've got this young physician who wants to observe this head and neck area injection. Are you fine with that?" And she was like, "Oh, I'm embarrassed. I have cancer. I've lost all my hair, and I'm wearing a wig today. And honestly, doctor, I don't want to have this young physician, see my bald head and take off my wig for you to do this procedure." And he's like, "Oh, no problem." And I mean, this is an expert, like you'd be shocked. He injected her through her wig, like in multiple and that just goes to show you how safe like the head and neck area is. It's so vascular that the chance of infection is slim to none. But I was like, whoa, I don't think I would have done that. But that was definitely
a stretch.
It was an eye-opening and kind of a funny story to tell to this day. Our next question is if you're concerned about pneumothorax, how long after an intercostal nerve block do you look for evidence of a pneumothorax? Assume that you don't get a post-procedure chest x-ray anymore, but do you look for lung sliding? And David, you mentioned the long sliding, so I'll let you kind of comment on that.
Sure. So basically, when I'm doing these blocks, I got to the point where I'm pretty much visualizing my needle from start to finish. Of course, you might need to find it at first, but you're not in deep when that happens. And I learned that the hard way. So I know I'm not in the pleural cavity because I realized my depth. So I'm not getting very crazy about sending them for post-op chest x-rays. I might say, hey, if you get short of breath, let me know. If you're really short of breath, call 911. But I never really even need to say that because of, maybe if there's a question that I could have been that deep, I'll say that to them. But I just say, hey, the risk is collapsed lung. Any problems breathing afterwards, let me know. But usually I do the block and they're good to go after being observed in the office for maybe 20 minutes. And they have a number to call if there's a problem. But thank God it's never been an issue.
Yeah, I'm going off of symptoms. So you're exactly right. I don't do a post-procedure chest x-ray. I kind of have the patient stick around for 15 to 20 minutes after the injections are done. All my injections are done under some image guidance. So in that case, I already feel good about it. I don't want to say ignorance is bliss, but I'm not going to go looking for a problem. I'm going to have the patient tell me if they have any symptoms afterwards and just hold on to them for 15 to 20 minutes after the procedure. But I'm not going to go try to find an issue if they're not complaining of one. We got another question that came in, and actually, I've never heard of this medication. Have you ever injected Exparel? I don't know.
Liposomal bupivacaine. Yeah, it's used mainly in the OR. We're not using it in the office so much yet. So,
is this a liposomal bupivacaine? Okay. Yeah, I've had no experience with that. Have you had experience with it?
I've used it for quite a few things. The Greater Occipital nerve region, I have not used it, but I won't be surprised if that's going to be available soon. I have no inside knowledge about that, but it's just a product that it lasts 72 hours to block. So the company probably will try to get into the pain realm, I would imagine.
Yeah, so unfortunately, it sounds like David and I can't really give you any good expert guidance on this. It's such you're at the cutting edge of thinking about using this that you'd probably have to look and do a research.
It's not standard care. I wouldn't do it until you get the green light from everybody. So,
yeah. There's no other questions right now. If anybody has anything, feel free to put it in real quick. David, any or Dr. Rosenbloom, any last tips or tricks or anything you want to, or main point you want to get across to everybody?
The main point, first of all, look before you leap. If you know you're not in the lung, you're not in the lung. If you watched the whole time from start to finish and you found your needle, don't go crazy worrying about it, but of course be prepared and inform the patient, do everything by the book. And yeah, the ultrasound and these great needles have helped us do so much for our patients and avoid surgeries and more invasive procedures than we need to do. So, I think it's just a great opportunity. I want to thank PAJUNK as well as ASRA and Dennis for helping us put this together and putting, thank you.
Thank you. I just want to end with exactly right. Like, I think our whole goal is to help people. And by doing that is to get a good outcome with minimal complications. And I think that's best done by, performing these injections under some type of image guidance. And ultrasound is probably the easiest, quickest way. But ultrasound is not perfect, and using other equipment like a PAJUNK needle with cornerstone reflectors to always have visualization of your needle is key. And I think you'll be happy because you'll get good results with no complications, especially if you're just starting out in your career. That's the goal. You want to make a good reputation for yourself and not have something happen early that can tarnish your name in the community. And I want to echo what David said, that just want to thank PAJUNK, Paulina with PAJUNK, Marco, the CEO, for working with David and I, and ASRA for giving us a platform to host these webinars. Hopefully there's more to come. So TBD. Yeah, it's 4:50. We finished about 10 minutes early, but I think that's plenty of time for everybody to go enjoy their evening and have a good night.